from the sympathetic chain, the splanchnic nerves are coming. Greater splanchnic, what is the root value? T5 to T9 is the greater splanchnic now. Lesser splanchnic, T10, T11. Least splanchnic, T12. So they are coming through the aortic aperture and they are joining the celiac ganglion. Celiac ganglion is one, so this is celiac artery, celiac trunk. Celiac trunk on either side, all together we call it the celiac plexus. Right? Some fibers are joining here, ending here, and from there the second order neuron. Some fibers comes down to form the mesenteric ganglion. Some fiber still comes down to form the aortic-renal ganglion. It's like that. So celiac ganglion or celiac plexus, better term is celiac plexus, because ganglion is for the only for the efferent fibers. But our target when you are doing the block, our target is the afferent fibers. Though we cannot block separately the afferent fibers, collateral damage will be there. Efferent fibers also will be blocked. But our target is afferent fibers. That is the reason why celiac plexus block is a better term. And celiac plexus block can be done on either side, or it can be done in the only one, because we are giving a larger volume that will be spreading. So whether you are doing under the ultrasound guidance or whether you are doing under the CM guidance, where is our target? This is aorta, anterior to the aorta. Anterior to the aorta, around the celiac trunk. This is our target. So when we are doing under the ultrasound, we are looking for the celiac trunk, celiac artery. So seagull sign, there is, it is getting branches. But when you are doing under the CM guidance, we cannot see all those things. We can see the aorta when you are injecting the dye, but we cannot see these other arteries. Sometimes celiac artery, celiac trunk is also sometimes seen. So when the dye is going encircling the celiac trunk also, but not always we can see. So our target is here. So celiac ganglion is which level? So it is not just in front of the teeth. Again, there is a mistake in the diagram. So it is little bit down. It is at the level of the L1. Right? It is at the level of the L1. This picture was in that way. It is little bit down. It is at the level of the L1. Sorry, this is at the level of the L1. And there are different approaches. One is called your antecrural. So this is the crus of the diaphragm, right? So when your needle is going anterior to the crura of the diaphragm, we call is antecrural. An antecrural approach, we are closer to the celiac ganglion, celiac plexus. And if you are going through the aorta, through the aorta, then it is called transaortic, antecrural, transaortic. Or when you are doing not going through the aorta, we can put needle on one on this side, another on the other side. That is your classical Capiz approach. So there are a lot of different approaches are there. I'll be showing you when I'll be doing the procedure, demonstrating it. So first one is your antecrural approach. That means when your needle is anterior to the crura of the diaphragm, it is antecrural. When your needle is going through the aorta, then it is called the transaortic. And classical Capiz approach is antecrural, but you are putting needle not going through the aorta. You are going on the either side of the aorta, one on the right side, one on the left side. This is also antecrural. What is retrocrural? Retrocrural is you are here, and you are giving a larger volume here. That means you are at the level of the T1, T12, but your ganglion is a little bit down. As I told you, this is the schematic diagram is not perfect anatomically. So this should be a little bit down. So when you are giving some volume here, what will be the fate of this volume? It will be going through the aortic aperture and will be doing it. So what is retrocrural approach? Retrocrural approach means your needle should be posterior to the crura. This is posterior, this is anterior. So that is your retrocrural approach. So antecrural approach means you are crossing the crura, you are in front of the aorta, then it is called through the aorta, transaortic. Either side of the aorta, that is your classical Capiz approach, or it can be retrocrural approach when you are doing it here. Now, what is splanchnic nerve block? Splanchnic nerve block is basically similar to that of the retrocrural approach. So there, your target is these splanchnic nerves. These splanchnic nerves are coming down along the T12 and T11. So when you are doing the splanchnic nerve block, you have to keep two needles, one needle here, another needle here. So your target is these splanchnic nerves, because celiac plexus is formed ultimately by the splanchnic nerves. The fibers are coming from the splanchnic nerves. So 95% of the celiac plexus fibers are from the splanchnic nerves. And the rest 5% comes from where? Some coming from the parasympathetic vagus, some comes from the T12 or other somatic fibers. So can also be mixing up, but mostly it is via the splanchnic nerve. So if you're doing the splanchnic nerve block, but splanchnic nerve is much more compact. Again, it is a schematic diagram, so it's not perfect. So splanchnic nerve is much more compact, smaller area. What is the advantage and disadvantage? This is a large area. What is the size? Its size varies from the 2.5 centimeter to 5 centimeter. So large plexus. What is the advantage? If we are putting the needle somewhere, the failure rate chance is less because it is a large area. And if you are giving a larger volume, it will be covering nicely. What is the disadvantage? You cannot do a precision listening. Suppose you want to do the radio frequency. Can you do it here? No. Why? Because it's a large size. Radio frequency listen size is very small. It will not cover. So you cannot go for the radio frequency listening for your celiac plexus. But because these fibers are much more compact, you can do the splanchnic nerve radio frequency listening, but you have to do at 4 sites. One at the level of the T11, one at the level of the T12, on the right side as well as on the left side. So that means the splanchnic nerve block advantage is you can do the radio frequency, and if you are doing the radio frequency, what is the advantage? Radio frequency neurolysis gives a durable pain relief which is lasting for 2 years, even more than 2 years in some situations. Whereas when you're doing the celiac plexus block, you have to only option is to use alcohol or phenol. You have to use chemicals because these chemicals are finally be spreading along the whole of the celiac plexus and it will be doing the neurolysis. What is the disadvantage of this? Disadvantage is because chemical neurolysis effect do not last for longer time, approximately 6 months. If you're using alcohol, then it's approximately 4 to 6 months, right? So celiac plexus block for the cancer patients who are not surviving long time, so it's okay with the alcohol. But celiac plexus block is not a good choice for the chronic pancreatitis. Why? Because you cannot repeat it every 6 months. Who is going to survive for the long time? It can give a temporary relief only. But for the chronic pancreatitis, benign conditions, better to do a splanchnic nerve block. Then you can do the radio frequency and you will be able to give a long-term relief. So splanchnic block and celiac plexus block indications are more or less same. Upper abdominal pain, visceral pain coming from the viscera, that is very important. Upper abdominal visceral pain. If it is coming from the apparatus, celiac plexus block is not going to help. Suppose there is an interruption of the peripheral terminal branches of the intercostal nerve, anterocutaneous branch. It's also called the acnes, anterocutaneous nerve interruption syndrome. So that kind of abdominal pain, upper abdominal pain will not be covered by this one. So it must be coming from the visceral, upper abdominal visceral pain, like stomach, like pancreas, like hepatobiliary tract. Then the celiac plexus block and splanchnic block, both are going to help. But celiac plexus block failure rate is less because there is a large plexus, more chances of success. But you can use only alcohol or phenol, and your duration of action is not longer, only 4 to 6 months. So it is okay for the cancer patient, but not okay for the benign conditions. Whereas splanchnic nerve block, you can use a radio frequency and you can give a long-term pain relief. This is the difference. I'll be showing you both the celiac plexus block as well as your splanchnic. I'll be also showing you all the different types of celiac plexus. And also I'll be showing you, demonstrating you the hour modified techniques, which was published in 2009.
First, I'll be describing the celiac, and then I'll be talking about the splanchnic. So, if you can remember, the celiac plexus is situated in front of the aorta at the level of the, which level? At the level of the L1. So, first, that means we have to go in front of the L1, in front of the core of the diaphragm, what I explained in the picture. And if we are going in front of the aorta, through the aorta, then it is called transaortic. But original Capi's approach was on the either side of the anterolateral part of the vertebral body. You look at here. So many a times we draw this picture So how this picture is drawn? So picture, this is your T12. So one line is drawn here, another line, one line from the T12 along the 12th rib here, another line is here, and then along the L1 we are putting the spinous process of the L1, we are putting another line, and where it is cutting, this is your needle entry point, and there we are not doing in tunnel vision. There we are trying to hit this part of the vertebral body, and then when we are hitting the vertebral body, then we are increasing the angle and we are going further. So one needle from here, it will be coming here, another needle will be coming from here, it will be there. So two needle, this was the original classical Capiz approach. I'll be putting these two needle there. First, this original Capiz approach. You can see here, this is your, one needle entry point, and that is another needle point the other side. So this is a triangle basically. You can draw the triangle or you may not draw the triangle, just triangle along the 12th rib, lower part of the 12th rib, and another line along the spinous process of the L1. So where they are cutting, normally they are cutting at around 5 to 7 centimeter from the midline, and or you can palpate it. Palpate the paraspinal muscles will be going like this, and if you are palpating, so you can draw another line here which is cutting the 12th rib, that is also needle point. It comes the same. So there are three ways to find out the needle entry point. One is you are drawing two lines along the 12th rib, drawing another line along the L1 spinous process, and where they are cutting with these two lines, that is the needle entry point. This is one way. Second way is from midline you are taking a 5 to 7 centimeter line, a horizontal line which is cutting this 12th rib, or you can palpate the paraspinal muscles that will be lying vertically, which is cutting at the level of the T12, that is another point. So needle entry point is where it is cutting. And first, what should we do? We should go. So this is your needle entry point. And first, what we are doing, picture, we are trying to hit the vertebral body. 12, which vertebral body? So L1 vertebral body. I am hitting vertebral body there. This is not tunnel vision procedure, remember it. This is original classical Capiz approach. And then I am increasing the angle. I am increasing the angle. I am staying hitting the vertebral body. I am increasing the angle further. And now I am not hitting the vertebral body. So now I am going passing vertebral body. And that is, I'll be checking by the lateral view, but I'll putting another needle from the other side, because you have to put it two needle from the either side. So then again, I am trying to hit the vertebral body there from the other side. First, hitting the vertebral body here, and then again, I am increasing the angle, and now I'll be missing the vertebral body, and by the lateral view, my needle should be just anterior to the vertebral body. I'm taking out this two needle. That was basically a marking. So you see, picture. So just here, like the lumbar sympathetic, I was initially touching the vertebral body. Now I have just missed the vertebral body. So here is your end point. But it is the original classical Capiz approach. It is antecrural, anterior to the crura, but at the level of the L1, but posterior to the aorta. So if I am drawing the aorta here, aorta is little bit, this is your aorta. So my needle is posterior to the aorta, but cross of the diaphragm is your, how to make change color. Okay, so this is your crura of the diaphragm. It comes like that. So it is antecrural, but posterior to the aorta, and you have to, where is your celiac trunk? Celiac trunk is here. Celiac trunk is here. Celiac trunk is here. So your needle should be coming here. Celiac plexus is around here. So you are giving a volume from either side, expecting that this volume will be spreading the whole area. So this is your antecrural, classical, but it is posterior to the aorta. right? I'm keeping this needle in position. So now I'll be showing you the retrocrural. Retrocrural, it should be 12th rib, it should come here. Along this, it should be coming posterior to the crura. Exactly same. Instead of here, we are at the level of the L1. We will be at the level of the. We should be at the level of the T12, and we have to again give the large volume, expecting that will be coming towards your aorta. Go above again. And remember, the retrocrural and the splanchnic is almost similar. I'll be putting one needle for the retrocrural, another needle I'll be putting it for the splanchnic. So, what should be done here? I should be at the level of the T12 level, right? So again, almost similar picture, almost similar. I'll be hitting the vertebral body first, picture.
Sir,
And then
you
again,
clear the drawing on the screen.
I'm hitting the vertebral body again. I'm increasing the angle. I shall be now going. I was initially hitting vertebral body. Here I'm hitting vertebral body, increasing the angle. And now I'm slipping off. And now I am pushing lateral. I'm putting only one needle here. Remember, these ribs are much more posterior. I am on the lateral, I am just hitting the vertebral body there and increasing the angle and going in front. This is your retrocrural. Why? Because I told you, I have shown you the crura. So exactly the similar, but here, because the crura of the diaphragm is like this, so if I am at the level of the T12, then I am retrocrural. I should not be introducing the needle further. My needle should be just crossing, just like the lumbar sympathetic. But when I am doing the splanchnic nerve block, it will be little bit different. I'll be coming to the splanchnic nerve block now. Chalo epi. Splanchnic nerve block, it can be done in the same way, but I'll be showing you the classical approach how the splanchnic nerve block is recommended to be done. Photo needle, photo 10 centimeter is okay. So first again AP view, then end plate squaring. So where the cappies and the retrocrural approach, all those I am not doing anything. I was having it just through AP view. That's all. So here I'll be making the end plate. My target is at the level of the T12, right? So end plate is squared. So here the end plate is squared. Then I am making it. Okay, just before that, one very important thing is I am putting a marker at the midline along the spinous process. Okay, and then from there along the 4 centimeter distance. So this is 2 centimeter, 2 centimeter. So along the 4 centimeter distance, I am putting another needle here, another marker here. So this is your, what I call it, Lakshman Rekha. I must not go beyond this. That means, put picture again. So this is 4 centimeter from the midline. I must not, my needle entry point must not be beyond 4 centimeter. Why? Because at the level of the 12th rib, we are having the pleura. So I must not be picking the pleura. So now this is AP view with the end plate squared. I'll be now making it oblique towards my sides, ipsilateral oblique. And how much oblique should I do? Still more oblique till the line comes closer to the lateral border of the vertebral body. Arekto? Show me picture. Okay, now it's almost closer to that. So my needle entry point will be here at the triangle, just below the rib picture. This angle below the rib, lateral side of the vertebral body, this is my needle entry point. And I should go tunnel vision and I should be trying to hit the vertebral body there. I'm hitting the vertebral body there. Now I'll be slipping up. I have slipped up. Now lateral. How much should I go? For the retrocrural celiac plexus block, my needle was up to the anterior bottom of the vertebral body. But here I shall not go that much. Here, my needle should be at the junction of the posterior 2/3 and anterior 1/3. Okay, so this is my needle, which is here. So what I am doing, I'll be advancing, and is very important is when you are giving the exam, examiner will be seeing that whether I am touching the vertebral body. So it should be scratching the vertebral body and scratching it. And I am going anterior. How much should I go anterior? Not that much. That is for the retrocrural celiac plexus block. Here I'll be there just this much. That means junction of the anterior 1/3 and posterior 2/3. This is your Splanchnic. But again, I have to place 4 needles, 2 at the level of the T11 and 2 at the level of the T12. So you understand, Splanchnic, celiac, almost similar, just minute difference. And these are the classical approaches of retrocrural and the original Capi's approach by drawing the different triangles. Now I will be showing you one very easy technique developed by us, and we published it in 2009 in our Indian Journal of Pain. So that is a very easy technique, and that is a the tunnel vision technique, because tunnel vision is very easy for us. For the pain physicians, we are very fond of tunnel vision. So here, what we'll be doing? First step is like all other lumbar procedures, end plate parallel. So for making the end plate parallel, for the upper lumbar and the lower thoracic, we need to make a cranial tilt. Why? Because it is a kyphotic at the level of the thoracic area. So we have to make a caudal tilt. Picture. So now the end plate is parallel. At the level of we are making the end plate parallel of the T12L1. And now what we are doing? We will be making ipsilateral oblique till the transverse process is vanished. You can do both the side, but we do it most on the left side. Why? Because aorta is on the left side. So that is the reason why we will be doing the aorta. I am taking off this needle so that he will be, otherwise he will be having this. These 2 needle I am taking off. So now look at here. So what I have done, I have made this end plate parallel, squared. This is the 12th rib. This is the lateral border of the vertebral body. Transverse process is here. It is buried within the vertebral body. Transverse process is no longer visible. It is overlapped. So now you can imagine a triangle here. This triangle, one side is bounded by here, by lateral border of the vertebral body. One side by the lower border of the rib. And base is imaginary. It is open. You draw a line, imagine there. And at the middle of the triangle, our hypothesis was, this is based on the study of the several your CT scan reports. If we are at the middle of the triangle, if we are passing the needle, tunnel vision, it will go through the aorta. This was our hypothesis, and we did it several cases. Initial publication was on the 25 cases. So you can read it. I will be sharing this article with you. So if we are pushing the needle here, it will not be touching the periosteum, not be touching bone. What is the advantage? Advantage is that it is easy to do because we are doing the tunnel vision. And second is, it is not at all painful procedures because you are not touching any bone. Original Capi's procedure, what was there? You are hitting the vertebral body, then increasing the angle, scratching and going anterior. It is very painful procedure. But here we are not touching any bony structure. You just find out this triangle bounded by the lower border of the rib, lateral border of the vertebral body, imaginary, just middle of that triangle. You go by tunnel vision and you will be always hitting the aorta unless the tumor mass is distorting it. So let us do the procedure. So what we'll do? So this triangle, my needle entry point. So let me clear the drawings. So my needle entry point picture. Okay, so this is the middle of the triangle, right? So I'll be going by the tunnel vision. Here I'm not touching anything, huh? So you have to check by the lateral view also. Once you think that, okay, you are there. Okay, lateral view. Here I have to remember, you have to remember, we have to, when we puncturing the posterior border of the aorta, here we cannot show that. So we'll be having a feeling that you have punctured a rubbery things, and then you go further, you'll be feeling another border, that is the anterior, first your posterior, then the anterior border of the aorta. Then you give dye, you'll be able to see that it will be delineating the aorta, and then finally you can. So here you see, this is not the, this is just the anterior border. Here it is antecrural, but it is posterior to the aorta. So as I told you, aorta will be here. Aorta will be here. So you are antecrural, but you are posterior to the aorta. So I have to advance, I have to come here, right? So I'll pushing it further, and it is all tunnel vision. You are not touching any bone anywhere. So it will be approximately from distance from here to here, approximately it is 1.5 to 2 centimeter. You have to give the dye, you'll be able to see in the continuous fluoro that the dye is pulsating, dancing, and that matches with the patient's pulsations. And the dye will be finally spreading along the anterior border and the posterior border. And a dye will have to be there initially when your needle is within the aorta, the dye will be vanishing. You cannot see anything. And if you are continuous fluoro, dye will be going distally. And when you're again puncturing, the dye will be here and that will be pulsating. So this is the final position, and we have to check it by the AP view also. AP view, what we will see? AP view, the needle will be almost at the middle of the vertebral body. It should be crossing the, if you are having a true AP image, you see the needle is almost at the middle. You see, almost at the middle. Aorta is at the middle, little bit on the left side, but your needle should be almost, when you are crossing the aorta, then your needle will be little bit almost towards the center. So the dye should not be, so no, dye will be spreading in this view. Dye will be spreading like this, and dye should not be coming outside here or here. Dye will be along here only. And sometimes, if the dye is along the celiac trunk, you can see the pulsation of the celiac artery also. That will be pulsating like this. This diameter will be increasing and decreasing. Celiac trunk, because it is a cross section of the celiac trunk when you are seeing in the AP view. So this is how. So this technique is very easy, very simple technique. You just imagine the triangle, go into the center of the triangle, and go and check by the lateral view. So these are the all different techniques. Antecrural, posterior to the aorta, antecrural, anterior to the aorta, retrocrural, splanchnic. So these 4 different types of procedures are similar, but little bit of difference is there. And the best technique is, if the patients don't have any coagulopathy, if the patient don't have the aortic aneurysm, then you can go, and the coagulopathy is not there, then you can go through and through the aorta, then you will be close to your target. And the success rate is better, and the volume of the drug will be lesser. Only 15 cc is enough, 15 to 20 cc is enough for, the transaortic approach. Whereas original Capri's approach, how much volume need to be given? Either side 20 to 25 cc on either side you have to give. If you are doing the retrocrural approach, you have to give at least 25 cc on either side. Because if you have larger volume, you are expecting that it will be going anterior to the aorta and will be blocking it. But when you are anterior to the aorta, then lesser volume is needed.